Good morning, and my topic is collagen cross-linking. So, going back to the history a little bit, in 1970s, Siegel et al. Was the first person who thought about and discussed the cross-linking reactions. In over 1997, Spoyer et al. Was the first person to demonstrate that in a porcine eye. And 2003, Wolensek gave a breakthrough in vivo proving evidence that cross-linking can stiffen the cornea and stop the progression in all the patients, 22 patients, he did the surgery. So he gave the gold standard conventional Western protocol where we anesthetize the cornea and apply, go for a 7 to 9 millimeter removal of the corneal epithelium and go for 0.1% riboflavin 5-phosphate application for 30 minutes and expose it to UV ultraviolet A 370 nanometer wavelength light of 3 milliwatts for 30 minutes. And eventually, this is what happened, that riboflavin absorbs the UV light. It causes a photochemical reaction, generates a reactive oxygen species, as well as an anaerobic as an aerobic reaction. It causes increase in the number of covalent bonds between the collagen fibrils and also between the fibrils and the extracellular matrix. And riboflavin also proved that it shields the effect of UV light into the deeper layers of the cornea as well as into the intraocular structures. And it is very clearly proved that there is an increased corneal resistance to the degradation enzymes, which Ramesh Babu sir has clearly talked about. And there is an increase in the turnover time of the collagen, and eventually the cornea becomes more rigid and it becomes more biomechanically stable. And so Rustin's protocol, the merits is it's the most effective protocol which is studied extensively, and it had a lot of improvements in the visual performance in the long run by relatively causing improvements in the topographical indexes. But what are the demerits here? The main thing is a long procedure time. 90% of the patients have varying degrees of corneal haze, high chances of infection, high chances of corneal melt, and more oftenly what we are seeing is a progressive flattening of the cornea over years and years of time. And all these things were led the other cornea surgeons to think about what else we can do. And that's how they started thinking about not creating an epithelial defect. So they thought about the transepithelial collagen cross-linking, and where they went into the iontophoresis assisted diffusion of the riboflavin. All these things were reducing the complication rates associated with the epithelium, but they are proved to be less effective and they are not flattening the curves as they wanted to be. So then they started and implementing something called as the accelerated protocol, which is a off epithelium off procedure with reduced riboflavin soaking time, and they involved the photochemical reaction, saying that the same photochemical effect can be achieved by reducing the illumination time and by correspondingly increasing the radiation intensity. That's how the 3-minute, 5-minute, and 10-minute protocols came into vogue. And the 10-minute protocol won the race, and there are several in vivo studies which showed very clearly that it is safe, effective in stopping the ectasia progression. They also argued that when compared to the conventional protocols, the 10-minute protocols has less reduction in K values. They discussed that it can cause it is because of the attributably less energy reactions reaching in the stroma. It's all true. But even though if it is less, it has adequately proved that it is adequate enough corneal biomechanical stiffening is happening with the accelerated protocols, which is adequate enough to stop the progression. We don't want a cardboard hard cornea. We just want a stiffer cornea which can stop the progression. And there has been a lot of discussions about the oxygen depletion because of the accelerated rate of CXL, and that is very true. And they also introduced the pulsing mode of the UV light emission with various machines where there is oxygen availability is more controlled. So then all these things works only for up to 400 microns. They started talking about what to do for the corneas where the thickness is less than 400 microns and still not worse enough to do a DALC procedure. Then people came up with lenticular assisted techniques, but you know that the complexities in procuring or preparing a lenticule and the cost involved. and the cost. They then went in for a contact lens assisted 100 micron assisted thickness. So the only fact, it was an excellent procedure, but only thing is it's a hydrophilic in nature, so it might take away most of the riboflavin as well as the UV light into itself and transmitting very less amount into the corneal stroma. So it proved to be less effective. Then a breakthrough in the evolution came with Farhat Kafisi, where he introduced the subclinical sub 400 protocol, and he proved that he introduced the hypoosmolar riboflavin in the deepithelialized cornea when you're using a hypotonic or a hypoosmolar riboflavin. Because of the hydrophilic property of the stromal proteoglycans, it can increase the corneal thickness in de novo by in vivo, and it can be helpful for doing a C3R in sub 400 protocols. So what he did was he introduced so he made the soaking time of 20 minutes and 2 minutes interval, and intensity the fixed one with a hypotonic solution. He started applying for this riboflavin, and at the end of 20 minutes he went in and around the thinnest loci. He did multiple measurements of the corneal pachymetry, and whatever the pachymetry was achieved on table. And then he decided to use the UV radiation duration according to that particular pachymetry. So he had a variable fluence and a very customized treatment towards particular thin corneas. It worked really well. So coming into the machines, I'm not very I don't know everything about all the machines, but what I know is I am very comfortable and I really love the machine Avedro, which now I've been using, and I know that this machine is being withdrawn and it's been stopped in the market, but it has the additional features of a very good articulating limb, making it easy to move it close to the patient's face. And it has a joystick where you can fine tune the movements according to the patient's movement, eye movements. It has a very good crosshairs, and so it makes me easy to correctly focus on the cornea. And more than anything, I love the pulse mode, which helps me to do an accelerated protocol, whatever I want. But now recently, because this machine is getting away, then probably you have to get used to the other machines as well. But no, it's now lesser that the CLUVR from the Apasami machine. It has so many other good features, that it has a variable spot size so that you can do a cone-based C3R, and you have a dual aiming beam in this machine. It is one of the fantastic motorized eye focusing system for adjusting the working distance, and it has a built-in camera for you to view from the top, so that whether the effect is exactly going on in the place where you wanted to have it. And so, yeah, coming to the riboflavin, yes, if you see previously, yeah, it started with the dextran, and we all know that dextran causes dehydration and intraoperative stromal thinning, and because of that, the effects cannot be as expected. It can be really intensified, so we might have to move on to HPMC, which has a better solution and is a stable solution. It has a more enhanced penetration as well. If you see various other studies, most of the time these international studies are all used the parameters and the riboflavin, which has been given by Avedro, and ours for our level, for our country and our domestic use, it may not be always available. And what I use and been very comfortable with is the K-Link H riboflavin sterile solution, even though I don't have any financial disclosures. And it's a 0.1% riboflavin. Hypotonic is the one which I commonly use. And so coming to the clinical scenario with this back set of protocols and things in mind. So what if to do if you have to have a progressive keratoconus? So first you have to define a progression that we have definite criteria like one diopter of increase in K max or steep K, one diopter of increase in powers, or one Snellen line of reduction in a very fixed variable time of 1 year. So what two important priorities as a clinician we should have is, first, the non-compromising priority is to somehow stabilize the cornea. Second, not a second priority, what we always have to achieve is to try to improve the best corrected visual acuity if it is already less. So we have three things in our armamentarium: the photorefractive keratectomy with CXL, phototherapeutic keratectomy with CXL, and obviously the last but not the least is the CARES. Other than DALC, we have all these things. So I'm not a big fan of photorefractive keratectomy. I don't do it very often, but it's important for the completion for the discussion like this with. So here what they did is, and the epithelium is removed, and they went in for a topo-guided photorefractive keratectomy up to 50 micron ablation, where they concentrated to remove 70% of the cylinders and 40% of the spheres. And they did a short, brief period of mitomycin and CXL, and it is proved in many studies to be safe and effective in mild to moderate forms of keratoconus, and haze is a big issue. And personally, due to some reasons, I really don't follow this, because I feel that changing it goes in for a little higher ablation of the stroma than what I really want. So mostly I learned from JK sir, and what I'm practicing is phototherapeutic keratectomy, where we go for a transepithelial PTK ablation of 50 to maximum of 60 microns, and if necessary, deepithelialize the epithelium over the entire cone, and then go for the CXL, whatever the type of protocol you are following. And here it looks like it gives a better refractive outcome without reducing the corneal stromal thickness. And it is not removal of the cone, it is just a resurfacing or regularizing the cone. And CARES, sir is going to talk about, and CARES gives an excellent procedure where it can be used in very advanced cases as well. So coming to the next step, when you are decided to do a cross-linking, so what all parameters do you really have to see before deciding on the type of your surgery? That is uncorrected vision, or this best corrected vision, what is the spherical component, what is the cylindrical component, where is the axis, what is the subjective acceptance, is there a difference between subjective acceptance and the AR, what is the cone location, what's the thinnest point, where is it located, what's the corneal pachymetry in the mid periphery, and whether the presence of scarring and oak stray. All these things have real matters to do. So now, see, keratoconus, there are so many things. Like, let's say nowadays we are talking about subclinical keratoconus and then diagnostic keratoconus. And in case of diagnostic keratoconus also, you have this keratoconus with very good visual acuity, like unaided 6/6 also we have seen keratoconus, and very advanced cases of keratoconus, maybe the unaided vision is close to 2/60 or 1/60 also we are seeing. So having only two treatment modalities like a cross-linking or a deep anterior lamellar keratoplasty cannot justify for such a varied spectrum of disease. So that's how it makes us to think what extra we can do in our treatment armamentarium. So what I follow is like whenever the best corrected visual acuity is somewhere between 6/6 to 6/9, and with low or moderate powers, and the patient is really comfortable with glasses or at least with contact lenses, and is able to use contact lenses without any issue, then we should really think of not doing anything and just do an accelerated cross-linking and stabilize the cornea and come away with it. When the patient is having a best corrected visual acuity of 6/12 or less, and then you look into the corneal thickness values when the thinnest point is 440 or plus. Then when you look into this refractive errors, what kind of refractive errors? Is it a pure cylinder or a spherical error associated with it? Then you think of doing it. If it's a spherical error associated, I go for the phototherapeutic keratectomy with cross-linking. I give a disclaimer at this point that it is going little for the more into the cornea related topic than from the postgraduate related topic. I know that, but you have to know all these things, but not to confuse your examiner, but to practice in your later life. So it comes to the third point is that when you have poor best corrected visual acuity and advanced cases, thickness around or just less than 400 microns, mid peripheral thickness is good, then CARES with or without CXL would be a good option. This is how I think of customizing each eye for the procedure. So some of the case examples like 3 diopter sphere, 6 cylinders, improving only to 6/12. This was the cone location. Then post-operatively, post PTKC 3R, then 2 sphere and 2.5 cylinders, 6/6. She was able to improve into 6/6. And this is how the comparison map looked like with 60 micron transepithelial PTK over the epithelium and accelerated protocol. You can see how much the cone is regularized and the height is reduced, and this significant. If you see into the closer look, you can see that close to 20 microns is disappearing in the stromal side, and a significant flattening here. So how to plan it is it requires real experience. I learned it from sir, still learning it from sir. And if you see here, you have to see first you have to identify the cone location, you have to identify the steepest point, you have to know the horizontal linear maximum distance of the cone, and then over it you have to mark the X and Y coordinates and get it ablated. And the values for ablation is mostly from somewhere from 40 to 60, maximum 60 to 65 microns put along with the epithelium, and this is how it get regularized in this patient. The same similar procedure in a different patient, 5 sphere and 3 cylinders, improving only to 618, post-op improved to 66 with a very good improvement. You can see the significant flattening and significant cone height reduction with just a 25 micron stromal ablation here, and we over which we have done an accelerated procedure. CARES, it's an excellent procedure where many times we can combine CARES along with accelerator protocols also. This is one example of an abnormal, very advanced cornea where I had done a 8 clock hour customized CARE segment implantation following a femtosecond assisted channel, and a very good improvement in vision. In this case, we scraped only the center epithelium. The epithelium over the CARES should be left intact. This is the difference pre and post-op in the anterior scan. So all these things we have discussed about the use of cross-linking in keratoconus. Nowadays, the era is changing, and probably we will be forced to use cross-linking in the future and to some extent in a very modified version in a refractive surgery as well. So when to consider all these things, like whenever you have any 2 or more of these risk factors, like spherical equivalent is more for ablation close to more than 6 diopters, whenever you have a suspicious tomography, but it's not fitting into the criteria of keratoconus, and the thinnest pachy is less than 480 microns, and residual stromal thickness is between 250 to 280, and the Bellin-Ambrosio scale, as madam was saying, it's more than 1.65 with various other parameters, and some of the Corvis indicators are also abnormal, and you have a family history or ocular allergy and eye rubbing. So what are the options left for you? So you have 3 options like PRK or LASIK or SMILE, as in like any other refractive procedure, but you have the extra options here. So the various studies are going on, and they have not yet come to a very clear consensus over, as in like the Wollensack, we have not come to that. Probably we are nearing that. So we are in the interface, in the transition. So most of the PRK cases, they have used close to 90 seconds of riboflavin soaking, and the total energy was close to 2.7. In LASIK extra cases, there have been 45 to 120 seconds of soaking with riboflavin close to 1.4 to 2.7 total energy. SMILE, not much studies, but still probably they are trying to give a little more of energy close to 3.4. So there's a disclaimer that these parameters and protocols have yet to go a long way to refine and refine. So yes, so whenever it's not very uncommon that we see patients for refractive surgery, and they are very keen, they wanted to have a refractive procedure done with definitely sometimes borderline parameters, at least weekly 2-3 cases we see. And if you are very suspicious, don't hesitate to defer it, okay, or at least observe it over a period of 1 year or 2 years, and then you can still take a decision. But if you have to do it, then if you have a strong suspicion, it is always better to do it with a stabilization procedure. That's what, and it is very important that you have to disclose this to your customers and then only take a call. And refractive, now previously with the extra procedures, they were worried about the refractive corrections as a whole. But right now we are able to get a very good refractive correction even with extra procedures in a more predictable way. And we have to understand that CXL, when it is combined with refractive procedures, it's not a therapeutic option. We are giving it just a prophylactic option. So we don't have to have the old conventional protocols what we have used for keratoconus in mind. So probably we have to redesign everything new for them. So you should be bold enough to face the haze and interface issues and other issues whenever you go for an extra procedure. So having this in mind, very limited cases I really do it. And this was a case of where moderate powers, but I feel there is slight asymmetry in the left eye, as well as the thinnest point is 470 to 475. So I don't want to take a chance. I was not able to defer it, so at least I did it with the PRK extra, and over a period of time, anterior is showing I'm maintaining the corneal safety indices as well as the thickness. Case 2, this patient I waited for a year, and you can see some amount of asymmetry in the left eye, but thickness values are good, vision is stable, refraction is stable. So I did a PRK extra and got good results. The femtolasic extra is this is a patient where which I cannot forget that I had her grandparents. I operated cataract. Her parents are known to me, and they came first, and with the girl was getting married, so they wanted to have a LASIK done. And then I told with a heavy heart, no, madam, it's really high ablation for me. I think we can try to avoid it. And then 1 year later, they came back asking for, they were a little desperate that they wanted to have some procedure done. And I gave the option, and there was a steep foci as well, but it was very stable over a period of time, and thickness was good. And I took a femtolasic extra for this patient, and still have no surprises. And this patient is an interesting story. He had right eye 14 to 15 diopters, and left eye was 5 and 1 diopter. And I gave the option of ICL straight away, but he was not willing for ICL in the left eye. He went back and came back with me, or they had come with the decision that okay, right eye I want ICL, left eye no, people are saying that we can't try femto. I want only femtolasic extra. That's how the patients come nowadays. And then I told I want to do femtolasic with extra only, not to take any chance for you. And then I did it. Not much of surprises. So these coming to another 2 minutes, like probably corneal haze is seen in advanced cases. The 17-year-old small boy, like progressive keratoconus, I did an accelerator protocol, but heavy-heartedly I had to see at 5 days post-op that 460 vision, not improving. Epithelial defect was healed, but stromal edema and diam folds, central 3 to 4 millimeter dense haze. I started on loteprednol, but thinking what went wrong, but whether the excess riboflavin or a riboflavin reaction or a deeper defocus or is a higher levels of irradiation for that particular patient. The edema resolved, but the haze worsened, and vision did not improve at the 2 weeks time. And then I have to to stronger steroids, used it for a longer time. Over a period of a month, it started resolving slowly, and then with vitamin C and lubricants, tapered it. And over a period of 1 year, I got it back all with a very minimal haze and scarring. And then I was happy to see that he had a very good vision also because of reduction in spears, because of the central flattening and cone displacement. I was happy to see that, but the secret is like I've lost about close to 80 to 90 microns of stromal thickness. I am now worried that what will happen in a 17-year-old boy, and then he has a long life to go. So, and that is the most drastic issue with collagen cross-linking, especially with the conventional protocols, or is the stromal degeneration. It behaves as an anesthetic cornea. Immediate recent times, we have at least close to 8 cases being referred from various places, and all these cases CXL was done somewhere else, and we are not very sure of the parameters to analyze into deeper facts. That the case 1, C3R was done 3 years ago, right eye melting. Case 2, C3R was done twice, 14 and 10 years ago, and now right eye is melting. Case 3, both is C3R done 6 years ago, right eye is melting. And so SAR did a deep antilamellar keratoplasty in the first 2 cases, and we did have mushroom PK in the third case, and fourth case is a similar example. So now with what is there in our mind is like with the better understanding, we want to stabilize the disease, no other go, but we definitely don't want to see a haze, don't want to see any flattening, and don't want to have the stromal degeneration in the long term. But how this has to be answered by various other research things which we are working on. And what happens if CXL fails? Don't worry, you have so many options. You can directly go ahead and don't repeat the CXL, just go and do a care straight away, or you can go and do a beautiful DALC, no issues. Infectious keratitis, it is possible, very small numbers, fortunately 0.7%, but nightmares are all unavoidable in our profession, especially as a cornea people. We should be able to, you should have a strong mind to solve it. Day 3, Staphylococcus aureus infection. Day 3, Pseudomonas infection post CXL is all possible. It's a medical emergency. You have to run, you have to get the cultures done. You have to start specific fortified and combined antibiotics, and to get the results as well. And this is a very rare case of acanthamoeba keratitis, which did not respond to any of the medical therapy, and I have to do a penetrating keratoplasty long back, and we published it as well. and confocal proved the causes. So post CXL infections, it is there. It is very small numbers, and it will hit you sometime or other. But it's not the end of the story. With targeted therapy, you can scar it, and then we can rehabilitate it later, or you can go for a timely transplant, save the eye, save the vision, as well as save the person who did cross-linking for that patient.